This video is about the talocrural joint plantarflexion. The talocrural joint is a synovial hinge joint. It is formed by the articulation of the convex dome of the talus and the concave surfaces of the distal tibia and fibula. With 1 degree of freedom, the joint motion occurs in the sagittal plane around the medial-lateral axis. Plantarflexion is the action of bringing the foot down with slight adduction, supination, and inversion. The normal plantarflexion range of motion value is 50 degrees according to the American Association of Orthopedic Surgeons. The normal end feel of plantarflexion is firm due to the tension of the ligaments surrounding the joint.
Sir, hi. Ako din sa singon niya. Para na reason din nga nung nakadiri ron. Refer kasi mong doctor na mag-seek physical therapy services.
The therapist must assess the range of motion of the talocrural joint of the patient. The data gathered is useful for the early detection of affectation and choosing of the appropriate intervention of the condition. The therapist uses the plinth or a table where the patient will sit on. Use a goniometer, a tool for ROM assessment. Introduce this to your patient. The angle should be in 0-degree neutral position, with the foot at the right angle of the tibia. The foot in 0 degrees of inversion and eversion. The therapist must position the patient comfortably with the proper draping, and the patient must sit straight. To avoid further knee flexion and hip rotation, the therapist must stabilize the tibia and the fibula. Using layman's term, the therapist instructs the patient on the motion desired, or otherwise, provide a demonstration by performing passive movement of the talocrural joint. With one hand, the therapist pushes the foot downward on the dorsum to produce plantarflexion until resistance is felt. The therapist must not exert force on the toes to avoid inversion or eversion. Using the goniometer, the therapist positions the fulcrum over the lateral aspect of the malleolus and palpates the landmark. The therapist aligns the proximal or stationary arm with the lateral line of the fibula. The distal arm or moving arm is aligned, parallel to the lateral aspect of the fifth metatarsal.
Sir, bend down, sir, ha? 1, 2, 3, go. Bend, sir.
The therapist stabilizes the stationary arm on the tibia with one hand. The other hand maintains plantarflexion, aligning the moving arm of the goniometer and preventing the inversion or eversion of the patient's foot. After determining the value of the plantarflexion range of motion, the therapist reads the scale of the goniometer to the patient and records the patient's ROM.
So, kaya niya og 35 degrees. 35 degrees.
This video is about the metatarsophalangeal joint extension. 5 metatarsophalangeal joints are synovial condyloid joints, the articulation of the convex heads of the 5 metatarsal bones and the concave bases of the proximal phalanges. With 2 degrees of freedom, the motions of the joints are flexion-extension in the sagittal plane around a medial lateral axis and the abduction-adduction occurring in the frontal plane around a longitudinal axis. The normal MTP extension range of motion value of the great toe is 70 degrees and 40 degrees to the remaining lesser toes, which is according to the American Association of the Orthopedic Surgeons. The normal end feel of the MTP joint extension is firm due to the tension of the structures surrounding the joint.
Sir, hi. Ako din sa singon niya. Para na reason din nga nung nakadiri ron. Refer kasi mong doctor na mag-seek physical therapy services.
The therapist must assess the range of motion of the metatarsophalangeal joints of the patient, since the data gathered will be useful for the early detection of affectation and the choosing of the appropriate intervention of the condition. The therapist uses the plinth or table where the patient would lie on, and also a goniometer, a tool for measuring the ROM. Introduce this to your patient. The patient is supine or in sitting position, with the examined foot at the edge of the plinth or table. If the patient opts to sit, then he or she must be in a long sitting position. To prevent ankle dorsiflexion and so inversion-eversion, the therapist must stabilize the metatarsals. Using layman's term, the therapist instructs the patient on the motion desired, or otherwise provide a demonstration by performing passive movement of the metatarsophalangeal joint. With the thumb, the therapist pushes the proximal phalanx of the tested toe toward the dorsum of the foot, moving the MTP joint into extension until resistance is felt. The other hand is stabilizing the metatarsals to avoid dorsiflexion.
Tungod kay itong goniometer, lahi man sa og shape, sakit man siya. So we'll do some changes. Maigo man ang diri sa patient. So we will put it on the kaning lat medial line.
Using the goniometer, the therapist positions the fulcrum over the dorsal aspect of the MTP joint, then aligns the proximal or stationary arm over the dorsal midline of the metatarsal tested joint. The distal or moving arm is aligned over the dorsal midline of the proximal phalanx. Another method of the goniometer is situating the fulcrum over the medial aspect of the big toe's MTP joint. The stationary arm is by the midline of the first metatarsal and the distal arm over the medial midline of the proximal phalanx of the first said toe. With concise instructions, the therapist allows the patient to perform passive metatarsophalangeal extension as guided, or let the patient do the joint motion actively by bending the tested toe towards the dorsum of the foot until resistance is felt. At the end of the MTP joint extension, the therapist uses the hand stabilizing the metatarsal to hold and align the goniometer. The fingers of the hand that pushes the proximal phalanx must maintain the extension of the joint. After determining the value of the extension ROM, the therapist reads the scale of the goniometer to the patient and records the patient's range of motion value.
Eye level, so ang patient kay naa siya iyahang MTP extension is 50 degrees. Degrees extension, MTP extension.
This video is about the manual muscle testing of the biceps femoris muscle for grades 3 to 0. The muscular contents of the posterior fascial compartment of the thigh are the biceps femoris, semitendinosus, semimembranosus, and the hamstring part of the adductor magnus. The biceps femoris is a two-jointed muscle which functions as an external rotator and leg flexor, and also a hip joint extensor. It has two heads, the long and the short heads. The long head originates from the ischial tuberosity, being innervated by the tibial division of the sciatic nerve, while the short head arises from the lateral supracondylar ridge of the femur, being innervated by the common fibular division of the sciatic nerve. Both heads insert to the lateral side of the head of the fibula.
Sir, hi. Ako din sa mga single ni Canada. Reason din ano nakadiri ron. Refer kasi mong doctor na mag-physical therapy services.
The therapist must assess the strength of the biceps femoris through muscle manual testing, since the data will be gathered is useful for early detection of affectation and the choosing of the appropriate intervention of the condition. The therapist will only need a plinth where the patient would lie on. A blanket may be used for modesty. The patient is in a prone position, with both knees extended and both feet at the edge of the plinth or table. The leg is in an external rotation so that the heel is away from the therapist and the toes are pointing towards the therapist too. The test starts as grade 3 where there is no resistance given. The therapist's fingers are positioned on the lateral thigh to palpate for the biceps femoris. To test, the therapist instructs the patient to flex the tested knee through its available range of motion, while maintaining the leg in external rotation.
Kira, sir? Okay. Malikot tayo mag-ibot. Ganyan, sir. 1, 2, 3, go. Okay. Yun, okay. Walang kagalisod, sir? Okay. Sige.
Lateral hamstring test grading is 3 If the patient can hold the end range position but tolerates no resistance from the therapist, the biceps femoris is functioning fairly but not normally. If the patient cannot hold the end range position, his or her biceps femoris muscles are functioning poorly. So we must do another round of muscle manual testing without changing the position of the patient. The therapist in standing position initially flexes the knee about 45 degrees passively. The supporting hand is contoured over the ankle joint just above the malleolus, while the other hand palpates just above the posterior knee where the hamstring tendons are located. The lateral hamstring test grading is 1 if the tendons of the hamstring of the posterior knee become prominent, but the patient cannot actively flex his or her knee. If the tendons do not become prominent and there is no palpable contraction of the muscles, then the grade is 0 and there is 0 biceps femoral activity taking place. If the patient's tendons becomes prominent and there is an active knee flexion movement from the patient, there is a biceps femoris activity. The therapist can assess the muscle strength by asking the patient to position him or herself to a sideline position, with the test limb being the uppermost limb. Use one arm to cradle the thigh and place the hand on the medial side, just proximal to the knee joint. The remaining hand supporting the leg is countered at the ankle joint just above the malleolus. To test, the therapist instructs the patient to flex the knee through the available range of motion.
Okay, 1, 2, 3, go. Mabending mo.
The lateral thigh test grading is 2 if the patient can complete the available range of motion in sideline position, and there is no resistance given from the therapist. However, the biceps femoris is functioning poorly. This video is about the manual muscle testing of the gastrocnemius and the soleus muscles for grade 5 and grade 4. Together, they act as powerful plantarflexors of the ankle joint, which provides the main forward propulsive force by using the foot as a lever and raising the heel off the ground. The gastrocnemius muscle originates from the condyles of the femur and has 2 heads, and it inserts via the Achilles tendon into the most posterior aspect of the calcaneus. The soleus muscle is deep to the gastrocnemius, originating on the tibia and fibula, and inserts with the gastrocnemius into the posterior calcaneus via the Achilles tendon. Both are innervated by the tibial nerve.
Hi sir, ako di si Lane and I am your physical therapist for today. So the reason di ay nga nag-refer ka sa imong doctor na musiko physical therapy services is tungod kay magduta og manual muscle testing. So unsa na manual muscle testing? Ang tuyo man gud nato ron sa kaning na session sir is to check the strength of your gastroc and your consolius. Ang mo din siya mga muscles kuan gamit para kuan nimo kanang kinto nimo. So ang kaning manual muscle testing kay i-check lang nato unsa ilang kakusgon. Karon ang ato lang gamiton is kanilang gyud ang plinth ug ang or kaning table. Karon ang imong imbuhaton sir para lang ka diha human kay place kag 2 fingers. Okay, so imong button sir akay ako sa i-demonstrate sir ha. Ani imong button kanang stand ka on one leg lang niya. Imo ipiko ni ang usa nimo ka leg. Okay sir, tanawa lang sa akong button sir ha. Usa ha ay sa ibuhata. Mukinto ka. Kinto sa pinakakaya nimo nya down. Nya kinto na pud ka. Kana yung pinakagrabe nimo og 25 times ka mukinto ana sir. Ha? Sige, buhata na to na sir. Try na to ha. Kung kaya nimo kuan nako diri sir, mudaon ko ha. 1 2 3, go. Na. Na. Okay, sir. So, nakaya na nimo. Wala man kay sakit. Sige. So, yan ang tampi kastiin. Na. Okay, sir. Diri gyapon ko mo standby, sir, ha? Sa mantay mo. Position ta balik ato, sir. Na, ha? 1, 2, 3, go. Na. Na.